Hi, I'm Nancy Brown, CEO of the American Heart Association. Welcome to the launch of the new 2020 CPR and Emergency Cardiovascular Care Guidelines. Since the first CPR guidelines were published in 1966, the American Heart Association has consistently reviewed, updated, and published new guidelines to ensure the highest quality of care for people who need it most. We are the first and only United States training organization directly involved in creating resuscitation science and education. Our evidence-based approach to resuscitation is driven by our global volunteer network of science experts who help translate science into guidelines used by all U.S. training organizations and large numbers internationally. The pandemic has brought many challenges to the forefront, but in true American Heart Association fashion, we have rapidly responded. We are protecting medical heroes on the front lines, providing oxygenation and ventilation training to help healthcare providers treat COVID patients, while also offering a hybrid of resuscitation refresher courses. We launched an online adaptive learning course based on the interim guidance for resuscitation of patients with suspected or confirmed COVID-19, marking the first time an e-learning resource was introduced at the same time as a new guideline. No one should be in doubt with the American Heart Association by their side. We have unmatched leadership in resuscitation research, science, and education, and our bold advocacy continues to advance quality care. We were made for this moment, and the results reflect the determination and dedication of volunteers, donors, supporters, and staff. Today, you'll hear from many scientific experts about the updated guidelines, which not only address health disparities, but also transform opioid-related emergencies and the physical and emotional recovery after cardiac arrest. Together, we will be bold. We will demand change. We will swap challenge for opportunity. Together, we are a relentless force for a world of longer, healthier lives. Thank you for joining us.
Good morning. I'm Michael Hulley, the Vice President of the American Heart Association International. And I wanted to thank all of you who've gathered here today at our 2020 Guidelines Instructor Update Conference. This has really been a challenging year for all of us, but we're especially proud of our instructors. And I wanted to thank you for your heroic response on the front lines of healthcare, while continuing to support resuscitation training. For all of us at the American Heart Association, it's a privilege to work with you, and we appreciate your commitment to continuous learning and quality training. As you're aware, the American Heart Association has once again released its guidelines for CPR, emergency cardiovascular care, in October 2020. These guidelines are a culmination of years of research into the latest emergency cardiovascular care science and based on international global consensus. Following the science update, we apply this new learning to our training products and programs and are actively working to update, translate, and localize our entire portfolio to bring this information to you quicker than ever before. I'm excited about today's program to bring you an in-depth overview of many of the exciting materials, programs, and new training strategies that we offer to help you better meet the needs of your students. The agenda is packed with information about new science introduced in the guidelines and the tools you need to incorporate the science updates and new training materials into practice. We've also invited special guests who will share insights and expertise that you'll be able to put into practice in your next class. I wanted to say thank you for taking the time to attend this conference and for your commitment to continued learning and offering quality training to your students. I look forward to working with you today, tomorrow, and over the next many months and years to continue to find new ways to help you deliver quality training that ultimately saves lives.
Good afternoon, and welcome to the 2020 Virtual Instructor Update. My name is Glenn Van Den Houten, and I'm the Regional Director for the American Heart Association for Europe, Sub-Saharan Africa, and Israel. We are excited to present you with this update today. We will hear speakers on the 2020 guidelines, updates, education, and implementation. Thank you to all the speakers and to Robert Wales, who put today's event together. 2020 has been an extremely challenging year for all of us, and I would like to take an opportunity to thank each and every one of you, whether it be frontline healthcare workers, whether it be academics, or working in the community, for all your continued efforts to fight against COVID-19 pandemic. From all of us at the American Heart Association, I'd also like to thank you for your work this past year to maintain quality first aid, CPR, and advanced cardiovascular care training. Your efforts will offer more patients a better chance at life, and together, we will be a relentless force for a world of longer, healthier lives. Thank you.
Hello, everyone. My name is Marita Straccia, and I work with the American Heart Association as their international training consultant. As an AHA faculty and educator for almost 7 years now, I'm excited to see how the American Heart Association has grown in the EUA territory. We're especially grateful to our training network and how dedicated you all have been in continuing to provide quality instruction even in these difficult times. This is because you, as I, feel the responsibility and the importance our role has to improve resuscitation education and the impact training has on cardiac arrest survival. I want to personally thank each and every one of you for your passion and your commitment and everything that you contribute to making such a powerful mark on the lives of so many worldwide. I'm immensely proud to be a part of your team. Please enjoy the webinar, and I hope to see each and every one of you in person soon to continue in our journey to grow and stay strong together. Thank you.
It's my honor to introduce Dr. Stephen Brooks. Dr. Brooks is an associate professor in the departments of emergency medicine and public health sciences at Queen's University in Kingston, Ontario. His main research focus is cardiac arrest and resuscitation with a specific focus around technology solutions. He studies innovative ways to optimize the community response to cardiac arrest. Current projects include investigations into mobile applications to crowdsource basic life support for out-of-hospital cardiac arrest victims, the development of a miniaturized disposable AED, and the feasibility of a novel neighbors saving neighbors community first responder model. More recently, Dr. Brooks has taken a leadership role in the development of a national COVID-19 emergency department registry. Dr. Brooks is the chair of the science subcommittee of the American Heart Association Emergency Cardiovascular Care Committee. Dr. Brooks has participated in the creation of international cardiac arrest guidelines for over 2 decades and continues to play a leadership role in synthesizing evidence to practice.
Hi, my name is Steve Brooks. I'm an emergency physician from Queen's University in Kingston, Ontario, Canada. And I also have the great privilege of being the chair of the science subcommittee of the Emergency Cardiovascular Care Committee of the American Heart Association. I'm here today to tell you about the 2020 AHA guidelines for CPR and ECC science and education. In this session, we will cover how the AHA guidelines for CPR and ECC are created. And as well, I'm going to highlight some science updates for the adult, pediatric, and neonatal sections. Before we get into the details, I just wanted to highlight some key changes. There's a new recovery link added to the in-hospital and out-of-hospital cardiac arrest chains of survival for adults and pediatrics. As well, there are new specific recommendations for treating opioid overdose and cardiac arrest in pregnancy. There's a reaffirmation of the use of epinephrine in cardiac arrest resuscitation. There are increased ventilation rates recommended for pediatrics and much more. First, I wanted to tell you about how the evidence is evaluated that informs the development of our guidelines. The International Liaison Committee on Resuscitation is an organization that's made up of 7 ILCOR member councils from South America, Asia, Southern Africa, the US, Australia, New Zealand, Europe, and Canada. Together, this is a volunteer-driven organization which undertakes a rigorous and systematic review of the resuscitation science. And recently, this process has gone from an intermittent every 5-year process to a continuous evidence evaluation process. And it involves structured evidence evaluation, analysis, cataloging of literature, and rigorous scientific evidence reviews. ILCOR uses several different types of evidence reviews, including formal systematic reviews, scoping reviews, and more brief evidence updates. And together, the output of these evidence tools form the total evidence output from ILCOR. And this output then informs the national councils in the development of their guidelines. The guidelines writing committees will first assess important research questions or important clinical areas that they think are important in their local setting. And they first go to check if ILCOR has identified that area as one that they are reviewing. So the writing group checks to see if there's a systematic review or a scoping review available from ILCOR. If not, the Emergency Cardiovascular Care Committee submits a request to ILCOR to initiate a new review for that important topic. And if ILCOR is unavailable to do that review, then the AHA local writing group for the guidelines will then initiate their own internal evidence review process and incorporate the results of that review process with the ILCOR output to create the guidelines. In the process of creating guidelines, the writing group evaluates the strength of recommendation for each statement that it makes, based on the balance of benefit and risk for the topic of the recommendation. And as well, there's a level of evidence assigned to each recommendation that gives the reader an indication of the quality or certainty of evidence behind that recommendation. Guidelines are based on ILCOR's consensus on science and treatment recommendations document, but also it's internalized at in the local setting for clinical efficacy, ease of implementation, and systems factors that are specific to the jurisdiction and catchment area of the National Council who are writing those guidelines. So the ILCOR Science Review is a review of the published evidence, whereas the guidelines process really contextualizes that and makes it relevant for the folks who are reading those guidelines in that setting. And then what happens after the guidelines are created is the American Heart Association then translates those guidelines into high quality resuscitation and education training materials so that students receive the highest quality knowledge and skills. So moving on now, I wanted to review and identify some highlights and important pieces in the adult cardiovascular life support chapter. You'll notice that the formatting has changed with this 2020 guidelines into a knowledge chunk format. And one of the most useful aspects of this new format is a top 10 take-home messages. And you'll see these highlighted for each section of the guidelines. You'll recognize that in the adult basic life support section, that the emphasis on early recognition, early activation of emergency services, and a retrieval of the AED are reaffirmed and continue to be emphasized. As well, the importance of high quality CPR with cycles of 30 compressions and 2 breaths are also reaffirmed. You'll see in the adult cardiac arrest algorithm a new emphasis on the use of epinephrine early in the algorithm. Evidence from a new large RCT have demonstrated the benefit of epinephrine in the treatment of cardiac arrest. and evidence suggests that the use of epinephrine earlier in the algorithm may be associated with improved outcomes. So you'll see a handy visual reminder in the algorithm of epinephrine earlier in the algorithm. And this is especially important in non-shockable cardiac arrest rhythm situations. There's also a recognition that not every cardiac arrest is the same. So there are several new special situation algorithms, a couple of which I'll highlight here. First, the cardiac arrest in pregnancy algorithm highlights the importance of high quality CPR and ACLS interventions early in the protocol. But also specific to pregnancy is the use of lateral uterine displacement to offload the inferior venous cava and improve venous return to the heart, and also the early consideration and preparation for perimortem cesarean delivery, with a recommendation that is, if ROSC is not achieved within the first 5 minutes of the cardiac arrest, then that cesarean section moves forward. With the phenomenal impact of the opioid crisis in North America, there has been an emphasis of how to treat opioid-associated cardiac arrest in the 2020 guidelines, with the development of a new algorithm supported by a recent scientific statement. The focus here, again, is on identifying respiratory arrest thought due to opioid toxicity and using naloxone to recover ventilatory effort in those patients. Naloxone can be considered in cardiac arrest thought to be due to opioid-associated situations, but there is no evidence to suggest that it improves outcomes in cardiac arrest. So the focus remains on high-quality CPR and the use of an AED. Moving now to the post-cardiac arrest situation, we can see an updated and new algorithm for the post-arrest scenario in the 2020 guidelines. You can see in the initial stabilization phase, there's a focus on managing the airway, managing respiratory parameters, and managing hemodynamic parameters. In the bottom section, we can see highlighted continued management and additional emergent activities that may occur in the emergency department or critical care unit. And these items include targeted temperature management, brain imaging, and the use of EEG. The 2020 guidelines also include a neuroprognostication diagram, which outlines critical aspects of clinical management in this phase of care and also identifies several tools that can be used for neuroprognostication, including imaging modalities, electrophysiology tests, features of clinical examination, and serum biomarkers. Importantly, it's emphasized that none of these tools can be used in isolation, and instead, we recommend that providers incorporate multimodal prognostication at a minimum of 72 hours after normothermia to ensure that premature withdrawal of life-sustaining therapy is not done. Readers of the new guidelines will also notice that the chain of survival has been updated, both for the in-hospital cardiac arrest scenario and out-of-hospital cardiac arrest scenario, with the most important addition being the addition of a new link called recovery. And this emphasizes the importance of survivorship and the recovery of patients in the months to years after cardiac arrest. Patients often experience both mental and physical disabilities and challenges in this time period, and this link emphasizes the need to monitor, evaluate, and treat patients over this time period. Moving on now to the pediatric section of the guidelines, again, you'll find a handy summary of the top 10 take-home messages at the beginning of the pediatric section. The importance of high-quality CPR is reaffirmed as the foundation of resuscitation of pediatric patients in cardiac arrest. with a highlight and emphasis on making sure that adequate rate and depth of chest compressions are achieved and that we allow full chest recoil and minimizing any interruption in chest compressions. And this is important both for team members and also for team leaders to recognize. The importance of early epinephrine for patients in non-shockable rhythms is emphasized in the guidelines chapter, with new evidence in the adult world supporting this recommendation, but also information specific to pediatrics from a large observational study showing that pediatric cardiac arrest patients who receive epinephrine within 5 minutes of cardiac arrest have improved outcomes, including return of spontaneous circulation, survival to discharge, and survival with good neurologic function compared to patients who get epinephrine after 5 minutes. Extrapolating from the adult literature, we can also recommend that naloxone is used in respiratory arrest for pediatric patients. And similar to the adult section, we also recognize that the benefit of naloxone in cardiac arrest due to opioid toxicity is not confirmed, so the focus remains on good quality CPR. The most important change in the pediatric chapter is a change in the recommendation around the rate of ventilations per minute. 20 to 30 breaths per minute is recommended as the ideal rate of ventilation, both for patients with an advanced airway during cardiac arrest and also for rescue breaths. Evidence demonstrates that children who receive this higher rate of ventilation compared to more traditional breaths per minute have improved outcomes. And for ease of training, we've synchronized the recommendation both for children with an advanced airway during cardiac arrest and also patients who are not in cardiac arrest who require rescue breathing. The guidelines also emphasize the importance of bag mask ventilation during cardiac arrest. There is no evidence to suggest that use of an advanced airway provides better outcomes when you compare with simple bag mask ventilation. As well, this section recommends that we consider cuffed endotracheal tubes for use in children during cardiac arrest when they are intubated. Previous recommendations suggested cuffed or uncuffed endotracheal tubes could be used, but these recommendations emphasize the use of cuffed endotracheal tubes because evidence suggests that patients who received cuffed endotracheal tubes require less tube changes, less reintubation, and the incidence of subglottic stenosis is very low. We recommend that cricoid pressure is not used routinely because there's no evidence of benefit and sometimes it can impair visualization of the cords. Looking now to the pediatric tachycardia algorithm, you can see that this has been reorganized when compared to previous versions. In the 2020 guidelines, you will see that after a patient is identified with a tachycardia and having a pulse, there's a recommendation to evaluate the rhythm with a 12-lead ECG monitor. And then immediately after, you'll see that there's a recommendation to assess for cardiopulmonary compromise. This replaces the earlier wording of poor perfusion at a different point in the algorithm. After children are evaluated for cardiopulmonary compromise by looking for acutely altered mental status, signs of shock, or hypotension, we then go on to an evaluation of the QRS duration to identify whether the rhythm is probably a supraventricular tachycardia or instead a supraventricular tachycardia versus a ventricular tachycardia. And the appropriate treatments are outlined in the boxes below. In the post-resuscitation section of the pediatric guidelines, we recognize that resuscitation does not end with return of spontaneous circulation. We recommend that for all post-arrest patients, we avoid and treat hypotension, hypercapnia, hypocapnia, hyperoxia, and hypoxia. And for those children who do not regain consciousness after cardiac arrest, we recommend the use of targeted temperature management, either at 32 to 34 degrees Celsius, followed by 36 to 37.5 degrees Celsius, or simply 36 to 37.5 degrees Celsius. Seizures in children, both convulsive and non-convulsive, are common after cardiac arrest. So the recommendations include a statement that where continuous EEG is both available and there are trained personnel available to provide it, that continuous EEG be used to monitor for seizures and they be treated if they are detected. Treatment of seizures in children after cardiac arrest is associated with improved outcomes. And similar to the adult chapter, we emphasize that prognostic decisions on the base of neuroprognostication should be delayed until at least 72 hours after the return to normal temperature. We have included in the 2020 guidelines a handy post-cardiac arrest care checklist, which allows the care provider to recognize and implement the most important components of post-cardiac arrest care. You will also recognize that the pediatric in-hospital and out-of-hospital cardiac arrest chain of survival has also been modified and improved with the addition of the recovery link in the chain of survival. After cardiac arrest, pediatric survivors can have physical, cognitive, and emotional challenges and may need ongoing therapies and interventions. And it's also recognized that care providers and bystanders to cardiac arrest also require support. This is included in considerations involved with the recovery link in the chain of survival. Moving on now to neonatal resuscitation. You'll be familiar with the algorithm as things have not changed too much in the approach to neonatal resuscitation. You'll see here in the neonatal resuscitation algorithm that the top part of the algorithm addresses interventions required by most babies after birth, and the bottom part of the algorithm addresses interventions required by the few infants who require assessment and intervention for cardiorespiratory depression. The guidelines emphasize that preparation is required when considering neonatal resuscitation. We know that approximately 10% of newborns require some help breathing. So it's important that there is somebody dedicated to this task who is trained and capable to undertake these interventions in the room for every delivery. It's also important that that person has access to more help because approximately 1% of newborns need further and more advanced resuscitation. The guidelines emphasize that most infants do not require immediate cord clamping or resuscitation, and infants can enjoy immediate skin-to-skin contact with mom, as this is associated with improved health outcomes, including improved thermal regulation, earlier and continued breastfeeding, as well as parental bonding. Inflation and ventilation of the lungs in infants after birth remains a keystone of neonatal resuscitation. Initial steps continue to include warming, positioning, clearing secretions, drying, and stimulating infants after birth, with the use of respiratory support and positive pressure ventilation and corrective steps if indicated. Recent evidence suggests that delivery of babies through meconium-stained amniotic fluid does not require a change to these basic steps, and direct laryngoscopy is only required, and endotracheal suctioning is only required if obstruction of the airway is evident. Heart rate remains one of the most reliable ways to assess for the need for resuscitation and also the infant's response to resuscitation. Recent evidence suggests that ECG monitoring is more reliable than palpation to determine heart rate accurately. So where ECG monitoring is available, this is recommended. The indications for chest compressions during neonatal resuscitation are unchanged, as well as the recommended rate at 90 compressions per minute, synchronized with 30 breaths per minute. For infants who require parenteral therapies, umbilical venous catheterization is recommended as the primary access for intravenous delivery. Some providers, especially those who do not resuscitate neonates on a regular basis, may be more comfortable with intraosseous access, and this is recommended as a reasonable alternative. Evidence demonstrates that newborns who do not respond to 20 minutes of resuscitation have a very low likelihood of survival. So recommendations include that this interval is appropriate to initiate discussions with the team and family regarding the cessation of resuscitative efforts. It was recognized in the 2020 neonatal guidelines that not much had changed from prior guidelines. And this was reflective on a on a body of weak evidence. So the neonatal writing group spent a significant effort in identifying knowledge gaps to encourage research and improve the quality of evidence on which to base future guidelines. And these are identified in the chapter. Now that we've updated you on all the important science highlights, you can go to eccguidelines.heart.org to get more information and download the full guidelines. There are lots of resources for healthcare providers, instructors, and the general public. Thank you very much for your attention.
Well, I hope you enjoyed the presentation from Dr. Brooks, as he gave us a great overview of the science content of the 2020 guidelines for CPR and ECC. We've collected a few questions that we'll answer for you. I don't think we're going to get to all of our questions today, so we're going to create a document later that we will share with the ITCs, and they can share it with you as the instructors to answer all of the questions that you have through all of the sessions today. Our first question is about epinephrine. Can early epinephrine be used in shockable rhythms if there's already an IV in place? So we heard Dr. Brooks talking about the benefit of early epinephrine with non-shockable rhythms, but this question is about shockable rhythms such as pulseless VT and VF. So there's some existing trials that show benefit from delaying the first dose until after the second or third shock. The priority for these cases is high quality CPR and defibrillation. There's some concern that epinephrine will increase the oxygen demand to the myocardium and can increase the area of injury. So if we can delay giving epinephrine until after CPR and defibrillation, the patient will likely have a better outcome. Another question on epinephrine related to the Paramedic 2 trial. Why are we still using epinephrine? Well, there were two randomized controlled trials that were considered in the 2020 guidelines around the use of epinephrine. The Paramedic 2 trial from the UK was one of them. An analysis of the two studies did find some benefit to the administration of epinephrine, particularly if it was early in the resuscitation. The weakness of those studies was the median time of administration of the first dose of epinephrine was 21 minutes after the cardiac arrest. So that's pretty late into the cardiac arrest, and also other observational studies that have been done in the past have shown a greater benefit to earlier administration of epinephrine. So while there did seem to be some aspect of patients being resuscitated with epinephrine and having increased brain damage because of the prolonged resuscitation, we do believe that the earlier the epinephrine can be administered in those cases, particularly in non-shockable rhythms, the better the benefit. What about mechanical CPR? Studies have shown that there is no difference in the outcome between mechanical compression devices and a well-trained resuscitation team. So there are definitely uses for mechanical compression, particularly when CPR is not plausible, like in a moving ambulance or a helicopter, or when transporting a patient from one part of a hospital to another, if the need arises while they're still in cardiac arrest. So there's a big emphasis in the guidelines on chest compression fraction. How do we increase chest compression fraction? This is a really good question, and I think probably the most critical question when it comes to increasing survival from cardiac arrest. So the first step is to develop a plan before the code. Are all of your staff trained in CPR? Are they trained in ACLS, PALS? If there is a resuscitation needed today, who's the first person that's going to do compression? Who's going to take care of the airway? Who's the team lead? If you work in the emergency department, you should practice in the same context, like an emergency department or in a simulation center that is set up like your emergency department with the same equipment and the same space, the same size, and the same resources. If you're in EMS, you should practice on the floor or in the ambulance. You should have the same equipment that you'll have in real life. Practice, ideally, recording yourselves, then debrief and analyze afterwards. Where were your gaps in compressions? What can you do to shorten or eliminate those gaps altogether? Where is your nearest defibrillator? Is it an AED or a manual defibrillator? If it's an AED, how long does it take to charge? Can you do compressions while it's charging? Then you need to practice outside of your direct area. What if the cardiac arrest happens in the hospital cafeteria instead of in a clinical area? How long will it take you to get there? What happens if it's in a department you're not as familiar with? Do you even have access to that department? Does the code team have access to that part of the hospital? Ultimately, improving chest compression fraction and improving resuscitation is like any QI program. What does our response look like now? What is our baseline? What do we want it to be? And then how do we get from here to there by improving our training, improving our processes, and improving the systems? So next, we're going to move to a break, and you'll see a countdown timer on the screen for about 5 minutes before we'll resume again with our next session. Hi, it's my honor to introduce Dr. Mary Elizabeth Mancini. Dr. Beth Mancini is a professor, senior associate dean for educational innovation at the University of Texas Arlington College of Nursing. She holds the Baylor Healthcare System Professorship for Healthcare Research. Prior to moving to an academic role in 2004, Dr. Mancini was senior vice president for nursing administration and chief nursing officer at Parkland Health and Hospital System in Dallas, Texas, a position that she held for 18 years. Dr. Mancini received a BSN from Rhode Island College, a master's in nursing administration from the University of Rhode Island, and a PhD in public and urban affairs from the University of Texas at Arlington. In 1994, Dr. Mancini was inducted as a fellow in the American Academy of Nursing. In 2009, she was inducted as a fellow of the American Heart Association, and in 2011, she was inducted into the National League for Nursing Academy of Nurse Educators. Dr. Mancini is an active volunteer with the American Heart Association and ILCOR. She serves as the immediate past chair of the AHA's Education Subcommittee, a member of the Get With the Guidelines Resuscitation Clinical Work Group, member of the National Academies of Science Global Task Force on Innovations in Health Profession Education, and co-chair of the BLS Task Force for ILCOR. She has served as the president of the Society for Simulation in Healthcare, as well as having served as a member of the Royal College of Physicians and Surgeons of Canada's Simulation Task Force and the World Health Organization's Initiative on Training and Simulation and Patient Safety. Dr. Mancini has over 100 publications to her credit and is a sought-after speaker at local, national, and international conferences on topics such as simulation in healthcare, health professions education, patient safety, teaching, retention and outcomes related to basic and advanced life support education, emergency and critical care nursing, nursing research, and work redesign. We've had her as a speaker on many occasions at AHA conferences, and we're very happy to have her here today to speak with you about the new guidelines on CPR and resuscitation education.
Hello, and welcome to this program on the 2020 AHA Guidelines for Resuscitation Education. My name is Beth Mancini, and I'm a professor at the University of Texas at Arlington College of Nursing and Health Innovation in Arlington, Texas. I've been a volunteer with the American Heart Association for 40 years, and most recently, I'm the immediate past chair of the Education Science Committee, immediate past co-chair of the ILCOR Basic Life Support Task Force, and a current member of SKILL, the Science and Clinical Education Lifelong Learning Committee of the American Heart Association. I have no financial disclosures to report. In this session, we'll be covering the Resuscitation Education Science Guidelines that were recently published. We will specifically cover these guidelines and what they mean to you as an educator. But first, how are these guidelines produced? Resuscitation guidelines start with a structured evaluation of the evidence, analysis of the data, cataloging of the literature, and scientific evidence reviews using the GRADE methodology. There are multiple different kinds of reviews that can be done. A systematic review of the literature, a more narrow scoping review of the literature to determine whether or not there's new information that can be used to impact the guidelines, and then evidence updates. Each of these evidence review processes end up with a series of co-stars, or a consensus on science and treatment recommendations. This is developed by ILCOR, the International Liaison Committee on Resuscitation, which brings together all of the world's resuscitation committees to determine and evaluate the research. Once that is done, each of the resuscitation councils are able to develop their own guidelines. So the American Heart Association, science and clinical experts create guidelines for cardiopulmonary resuscitation and emergency cardiovascular care that are used in the United States and across the world. So each of the councils review the scientific guidelines, the co-stars, and they are able to determine, based on their local information, their ability to translate the science into practice with their local resources, how the guidelines are going to be established in their area of the world. This is why on some of the guidelines, there are differences across the individual councils. Now, there are also pieces of information that are important to education science, such as the impact of cognitive load on the ability to learn information or to translate it into practice, or such things as augmented reality, where there's not yet enough science to develop science-based guidelines. And in this case, we don't have those guidelines, but there is this wonderful resource that you can access. It's a free access, which is the AHA Scientific Statement on Resuscitation Education Science and Educational Strategies to Improve Outcomes from Cardiac Arrest. This is available to you, so you're able to look at some things that are guided by expert opinion and experiences that have not yet developed into guidelines. So I wanted to make sure that you were aware of this resource from the American Heart Association. So back now to the development of the guidelines. It's important as an instructor that you know the class of a recommendation and the strength of the evidence that stands behind it. So when we're reviewing these educational guidelines, I'm going to be showing you their class of recommendation and the level or the quality of the evidence. So the strength of the recommendation goes from strong, where the benefit significantly overstates the risk, to moderate, to weak, to no benefits, to harm. So we will be looking at each of these guidelines and recommendations as they relate to resuscitation education, and you will see the strength of the recommendation. And then you are going to look at the quality of the evidence. So was there high quality evidence from more than one randomized controlled trial? Were there moderate quality evidence, but that was from a randomized trials, or non-randomized, or is there limited data, or really it is simply expert opinion? So those guidelines are translated into products such as advanced life support or basic life support, whether they're ebooks or whether they're hard copy books, because we want to ensure that these guidelines are providing the students the highest quality knowledge and skills. The guidance that we use when we're talking about education is the Utstein formula for survival. And you may not have heard about this, but it's a very important concept. That is that the medical science, that which we know to be true in the treatment and prevention of cardiac arrest, cannot do it on its own. It must be combined with educational efficacy. We're going to talk about that a lot, but also times local implementation, the ability to get it into place. And only when those three things come together will you have the positive outcomes, the level of outcomes from cardiac arrest. So we're talking today about educational guidelines. So let's move to educational efficacy. How do we maximize the ability to translate medical science, combine it with local implementation strategies to improve outcomes? So educational efficacy covers two main areas: instructional design, how well and how we actually construct our courses and our programs, and provider considerations. In this case, providers, we're talking about those who go forth and actually use the skills that we're teaching them in basic advanced life support, and whether they're lay providers or healthcare providers, first responders. So we're going to talk about each of these separately and the guidelines that accompany them. So in the area of instructional design, we've clustered 4 areas of guidelines under the notion of improving CPR skill acquisition, how someone can learn the CPR skills, and how they best retain them. And we're going to talk about each of these 4 separately. So first, we're going to talk about deliberate practice and mastery learning, because the evidence indicates that these, when used properly, can improve performance. So here, just so that you will get a sense of how to look at these recommendations, the first column is COR, or the classification of the recommendation. It's a 2B, and level of evidence is a B, non-randomized. So the recommendation is incorporating deliberate practice and mastery learning into basic and advanced life support courses may be considered for improving skill acquisition and performance. Here we're saying that deliberate practice, which is a specific type of training approach where learners are given a discrete goal, immediate feedback, and ample time for repetition, will improve performance. And mastery learning is an additional concept that takes that notion of deliberate practice in the program along with testing that uses defined criteria to assure that the individual who passes this course has actually mastered the concept. So for you as an educator, this is saying, when you're incorporating deliberate practice and mastery into your programs, we have now designed the AHA products so that you will focus on deliberate practice and assuring that your learners are able to pass the programs at a level of mastery, not simply doing most of the things well, but all of the things well. Again, if we want to maximize skill acquisition and retention, we have found the evidence has been reviewed, and they have found that frequent booster sessions are associated with improved performance. So here we know that it's a very strong recommendation, a level 1, and the level of evidence is from randomized studies. And it's recommended to implement booster sessions when you're using massed learning approach. Now, what are these 2 words? Massed learning and booster training. So massed learning is what we typically have done for many years, it's a single event, single training event that lasts for hours or maybe days. But all of the information is packed tightly together, so massed together. What the literature is showing that if you boost the training by giving brief weekly or monthly sessions focused on repetition of content presented in initial mass learning, that indeed you are boosting their skill acquisition and you're improving their retention. So think about these concepts when you're delivering your courses. Spaced learning. Here again, based on randomized trials, we make the recommendation in 2020 that it's reasonable to use a spaced learning approach in place of a massed learning approach for resuscitation training. So here we're saying, take all of the information, and the programs are constructed and delivered to you in ways that allow for you to do this, and give it over time. You can do it in ways that allow the content to be very tailored, lasting for a few minutes or lasting for several hours. And you can break it up over weeks, or maybe you do it for months. But there is evidence that says this is reasonable to do and equal when compared to massed learning courses for particularly pediatric training, though there were no studies that compared for BLS, neonatal, or ALS courses. Here is another important characteristic of our programs that you as instructors need to focus upon and embrace. and that is that feedback devices improve performance when used during training. Now, what constitutes a feedback device? Corrective feedback devices are those that usually have a visual display of depth, while prompt devices provide an auditory tone to follow like a metronome. But we know these devices may cost money. So while there is a recommendation to use this, we also know that there's a need for further research to balance the cost of the devices as well as the potential increased cognitive load. So the recommendation is there, but we're also, in your role as an educator, you may be helpful in setting up further research that lets us know how to refine this. Now, we looked at how to enhance acquiring the skills and retaining the skills. Let's talk about overall improving resuscitation training. We're going to talk about recommendations related to teamwork and leadership training, high fidelity mannequins, training in the in situ environment, and gamified learning and virtual reality. Teamwork and leadership training has been shown to have a positive impact on providers during simulated and real cardiac arrests. So while there have been no randomized trials, it is reasonable to include specific team and leadership training as part of ALS training for healthcare providers. So you will see these more notably in the 2020 products, but it's very important that we embrace this and we move our mental model to ensure we're not just talking about skills, but also teamwork and leadership if we're going to maximize outcomes. So the 2020 guidelines and recommendations also speak to providing learners with more realistic training environments. And this can be done through in situ training. We note here that the recommendations that it's reasonable to conduct in situ simulation-based training in addition to traditional training. This is, when we say, the American Heart Association says in situ simulation, they're talking about activities occurring in actual patient care areas. It may also be reasonable to conduct these simulation-based training in place of traditional training. So we have noticed that these are things that sometimes are only dependent upon whether or not you have the opportunity to bring your simulation into the actual intensive care unit operating room. But again, when we talk about the fidelity, we're going to be talking about that in just a minute. We know that fidelity is dependent upon the environment, not just the capacity of the mannequins. So we want an environment that is realistic, so that the learners develop the skills and the attitudes and the responses based in that environment. Now, people want to know, is it important to have high fidelity mannequins? Well, there is some research in this area. Some of it is just expert opinion, however. So the use of higher fidelity mannequins for advanced courses can be beneficial for the learners who are at centers that have the available infrastructure and personnel. If they are not available, however, we still know that the use of lower fidelity mannequins during advanced courses can be considered and have been effective. But we also want to say in a 2020 guideline that it's reasonable to use mannequins in a manner that allows for alignment of the learning objectives to the needs of the individual learning group. If you have a learning group who is practicing in areas where they have a lot of equipment, then that's what you're going to be able to use for them, and it's appropriate because it is going to strengthen the learning, achieving the learning objectives. If they are working in areas where they have less equipment and less access to technology, then you work from that perspective always. So context matters, and the 2020 guidelines support that your education needs to have these considerations when you, the instructor, go out to teach. Now, with all the new technology, we're also looking a lot about gamified learning, which includes the use of serious games and leaderboards and virtual reality. But we have some randomized trials that tell us that gamified learning may be considered for basic and advanced life support training, whether for lay providers or healthcare providers. So certainly, as you're trying to increase engagement, this is an opportunity to do so when you're using gamified learning. And the American Heart Association's products also take that notion into, embrace it and help build it into their programs. Now, where there was not a lot of literature is in the area of virtual reality, as opposed to, in augmented reality, but where you add something onto the actual environment in which you're working. But the use of virtual reality based on non-randomized studies can be considered for basic or advanced life support training. So, what about pre-course learning? We all know that we want to have learners who come prepared for our courses, but we also know sometimes the learners don't. Their books, if they have hardcover paper books, may still be wrapped in the plastic. If you have given them codes to do materials online, they may never have accessed those materials online. But when we really look at limited data that we have, that's the CLD of the level of evidence, we know it is reasonable, it may be reasonable to incorporate pre-course e-learning into existing advanced courses. So there is evidence, limited that it may be, that having these pre-course preparations for advanced courses is useful. So when you see that as a requirement for a course, it is because there is some data that tells us it's a good thing to do. Now we know we're focused on improving the levels of bystander CPR in our communities. So the recommendations, there's part of the recommendations that are purposely directed at lay rescuer CPR and how we can improve those numbers. And COVID notwithstanding, we want there to be high numbers of bystander CPR. So we want to look at what is the impact of self-directed CPR training, doing community-based lay rescuer training, tailoring CPR training, and the use of feedback devices. So how effective is self-directed CPR training? Well, with limited data, we are still making a class 1 recommendation that a combination of self-instruction and instructor-led teaching with hands-on training is recommended as an alternative to instructor-led courses for lay rescuers. If instructor-led training is not available, so if the combination of doing both is not available, self-directed training is recommended. So again, focus on making sure that there is adequate time for individuals to do CPR training, and self-directed training has been shown to work. And how about training in middle schools and high schools? Again, after considerable review of the literature, the 2020 guidelines have a level 1 recommendation, class of recommendation, where benefit highly outweighs any risks. Though the level of evidence is limited, there is still a class 1 recommendation, and it is that we focus on the policy needs and the practical needs of training middle school and high school age children how to perform high quality CPR. Why? Because not only that they will do it when they're young, but they will carry and develop a lifelong commitment to doing bystander CPR, that they can make a difference and save a life. So we have recognized the importance of focusing on how we train bystanders so we can increase our CPR rates. And these recommendations tell us how we can do this. Based on the evidence, it's reasonable to train bystanders in compression-only CPR for adult out-of-hospital cardiac arrest as an alternative to conventional training. Now, there's only limited data here, but we believe that there is moderate strength of the recommendation, so it's important that we allow that to happen. It's reasonable for CPR training for primary caregivers or family members of high-risk patients. So targeting people who we know are at high risk and their caregivers and family members is very important. And it is also noted that the evidence tells us that we need to consider that the training needs to be done more than every 2 years for lay rescuers who are likely to encounter a cardiac arrest. We still do not know the optimum time frequency for having retraining or the optimum format, but we know it's important to think about. So, what about feedback devices when we're training lay rescuers to train them in CPR? Use of feedback devices can be effective in improving CPR performance. Level of evidence A. Many randomized control studies that tell us that indeed we can do this. So, if these devices are not available, auditory guidance, a metronome or music, we all think about the songs that have the right beat for doing CPR compressions, may be considered in order to improve performance. But we need to focus on the best way to do it, and that is use of feedback devices. Now, a new recommendation in 2020 addresses opioid overdoses. And here, while there's limited data, the epidemic in opioid overdoses tells us that it's important for us to add training. So the recommendation is that lay rescuers receive training in responding to opioid overdoses, including the administration of naloxone. And why would we want to do this? Because this intervention is known to save lives. So even though it's limited data, we believe that it's important to do in your training, and the American Heart Association educational products have this open and available for you. Now, provider considerations. We know not only the tools that we give you are important, but where do we apply these tools? We need to think about provider considerations. So disparities in education. For 2020, it's recommended that we target and tailor layperson CPR training to specific racial and ethnic populations and neighborhoods. We know that we can identify in the United States, there are other mechanisms around the world, but areas where there is low frequency of CPR training, we have to intentionally intervene and provide more training in these neighborhoods if we are going to see a decrease in the death rates from cardiac arrest. It's recommended that we also not just look at racial and ethnic populations, but low socioeconomic populations to the level of a geocode. So how can we do this? Individually, in your individual areas, intentionally looking at how the CPR programs are being offered and advocating that there's more availability in areas of racial and ethnic differences and low socioeconomic populations. The other important issue reflects that fewer female victims of out-of-hospital cardiac arrest actually receive bystander CPR, and that we need to include information in our educational training and public awareness efforts that specifically addresses this. To talk with your learners about it is acceptable in this case to put your hands on a female's chest. So in certain areas of the country, in certain areas of the world, this is a problem because of the ethnic and cultural biases established between males and females or these issues. And so we need to think about it. But if we are going to save women, we must talk about how important it is to be that a female victim gets early but high quality bystander CPR. We also have noticed that the frequency with which emergency medical system practitioners experience out-of-hospital cardiac arrest has an impact on the competence and the management of that cardiac arrest. So though there is limited data, there's a 2A recommendation that that EMS systems monitor clinical personnel's exposure to resuscitation so that the teams that are out in the field have members who have had frequent experience or recent experience. Now, there's a challenge in whether or not you actually have the staffing to allow that adjustment to always have people who've had experience on every team every day. But we can also look at training strategies, simulation strategies that allow people to stay as current as possible. ACLS course preparation, those people that we want to be able to do CPR in the hospital environment or the advanced cardiac life support environment. Sometimes we're asked, where is the evidence? What is the data? Is there data that taking an ACLS course makes a difference? And while there is limited data, it is a level 2A. So moderate evidence, here is a policy issue that there's CPR training in the community, mass CPR training, CPR awareness initiatives, and promotion of hands-only CPR events. You may not teach all of this, but you can promote and advocate for it. We know that we need to talk about the physical barriers that may impact bystanders' willingness to perform CPR, the issue of potentially doing harm to another individual. But again, with this limited data, we do believe that it may be reasonable for us to focus and heighten people's awareness on how we can overcome these barriers. And then the issue of emotional barriers to having bystanders willing to perform CPR. Though the data is limited, we know that there are situations where people are afraid to start. They've gone to training, but they're afraid to start. So for you as an instructor, what does that mean? Talking with them in the class that they will have these feelings, but how are they going to overcome them? Those are a lot of recommendations, but we know it's not all the information that we need. As we said, in some cases, we only have limited data. So we want you to be able to be aware of what we need to do going forward to get more educational research and how you can participate in that, support that, or wait and look and read for it for when it comes forward from others. But what are we going to focus on in the future? We're going to talk about defining outcomes of clinical relevance. Part of the problem with some of the studies that have led to this guidance or made it such that we couldn't is we didn't have defined outcomes that every study used. We want to establish links between performance outcomes, that's what we do at the end of training, and what actually happens to the patients when we apply the training. Do we improve patient outcomes? We know we need to talk more about cost effectiveness of our interventions. When we take a global perspective, there are higher resource countries and lower resource countries. What are the most important things we can do? That are the most cost-effective things we can do. And then we need to do more in how we develop the instructional design characteristics. How can our programs be even better than they are today so that they're tailored to the acquisition of specific skills? So the top 10 take-home messages. We will not maximize survival from cardiac arrest without effective education. Remember the Utstein formula for survival. It says that education, what you do when you are doing resuscitation education is every bit as important as any other science that we develop. Deliberate practice and mastery improves skill acquisition and retention, so make sure you take those key elements and apply them in your courses. Think about adding booster training because it improves CPR skills, and it has actually been shown that in the neonatal population, it improves outcomes when you add those booster trainings. Spaced learning approach improves clinical performance. So think about how you can do that instead of giving a mass of information, breaking it up into smaller, more manageable bits of information, and the use of feedback devices. We know that that's an additional expense, but it promotes skill acquisition and retention. Using high fidelity mannequins, teamwork leadership training, in situ training, gamified learning, virtual reality, all of these things can enhance training and maybe improving outcomes. We believe that they probably will show that, but build them into your programs as you can. Self-directed CPR is a reasonable alternative. There is evidence to show it's a reasonable alternative to instructor-led training for lay rescuers. Middle and high school students can be taught high-quality CPR, and it will carry forward in their lifetime. When we want to increase bystander CPR rates, we need to make sure that we are also looking intentionally at low socioeconomic neighborhoods and special racial and ethnic communities. Research is still needed into clinical outcomes, the links between the outcomes and training and patient outcomes, and cost-effective interventions. So as an educator, you are essential. Embracing and understanding the level of evidence and the class of recommendation of these recommendations is important for you. Why? Because then you understand what you're doing, why you're doing something, not just because you've been told to do something, but you can embrace it and build upon it. So thank you very much for taking the time to listen to this information on resuscitation education. Remember that as educators, our biggest challenge isn't getting new ideas into people's heads, it's driving those old ideas out. Let the new evidence guide your practice. If you want more information, now that you've been updated on the highlights, you can go to this website for more information, full review of the guidelines, and more resources that you can have to improve the outcomes from cardiac arrest. So thank you very much for the time you've spent with us today, and go forward and teach even more courses. Have a great day.
All right, well, thank you, Dr. Mancini. That was a great presentation. We have just a couple of questions that are about the education content, and then a few questions that are related to the next topic, which is implementation. So we'll hold those until after the implementation presentation, because I think you'll get some of those answered. So for education, can spaced learning be applied in AHA courses and resuscitation courses? So yes, there's a number of ways that you can do that. Spaced learning is just spreading the learning out over a longer period of time in smaller chunks to give people more of an opportunity to process and retain that information before it has to be recalled. We've seen a number of different models using this from training centers. Some will break an ACLS course into smaller chunks, for example, chunks of 2 or 3 hours at a time delivered over a few weeks. We probably wouldn't want to see that go over any more than 3 to 4 weeks. But by taking it into smaller chunks, it gives people time to process each step. But by continually going through that training and building upon the previous training, it gives them some opportunity to review and retain and review and retain more. On the AHA side, we've actually developed an entire program, a solution for training that's based on this exact idea, that by taking a large amount of training and splitting it up into smaller doses delivered more frequently, the students have better retention, and their skills actually are retained much more effectively than with absorbing a lot of information very infrequently. So we'll talk about that a little bit in our next presentation. We also have a question about waveform capnography. Does the student get training and technical education of end-tidal CO2? So in the ACLS course, we cover the use of end-tidal CO2 or waveform capnography in the airway management module. It's a brief overview. It's meant to familiarize healthcare providers with the use of measuring, primarily for ensuring endotracheal tube placement, but also giving a little bit of a broad overview of the use of end-tidal CO2 in the resuscitation setting. There is definitely a lot of information that you can glean from waveform capnography beyond just the number, the shape of the waveform, and the frequency of the respirations are helpful as well. But a lot of that information is beyond the scope of the ACLS course. But I would highly recommend, as a healthcare provider, particularly if you work in a critical care or emergency setting, that you do some education on that topic as well. Welcome to our final presentation of the day. We're going to talk about guidelines implementation. So we've learned a lot of good things about the science updates and the new educational design and philosophy. But now we're going to talk a little bit more about the details of how to run AHA courses moving forward. So all of these changes that we're putting into place into our programs are the result of one of two things: either feedback from our training network or educational design and science. So first, we want to talk about some key updates to the structure of our courses. We're going to talk about how we've incorporated some of those educational concepts that Dr. Mancini spoke about. We're going to speak briefly about digital training, and we'll talk about the AHA's digital products, and then some key resources for the AHA training network. First, we want to talk about the updated course structure. So if you've taught ACLS or PALS before, you're familiar with the pre-course self-assessment. This was a test that students would take online before they would come to the classroom that would help them to identify where their strengths and weaknesses were so that they could appropriately study as they come to class and prepare. That way they can make the best of the time in the classroom. We're building on that concept this time with a new idea called pre-course work. Pre-course work is a very important evolution in this process of helping students to prepare best for the part of their class that they spend in the classroom. This is designed to give students more time for hands-on skills practice and for practicing with a high-performance team. So there's going to be two options as we move forward for ACLS and PALS courses. Option one is the new course structure with pre-course work, and option two is the traditional course structure with the pre-course self-assessment that you're used to. So let's talk about option one first, pre-course work. Prior to class, the students will not only complete the pre-course self-assessment, they'll also complete a series of video lessons with knowledge checks. It's called pre-course work. So this will incorporate most of the time that a student would have normally sat in the classroom watching videos. They'll now do that before they come to class, and they'll do a few knowledge checks along the way to make sure they're paying attention. This is going to allow for more time to be spent in the classroom on skills and teamwork. So they complete their pre-course self-assessment, they complete a series of video lessons and knowledge checks, and this allows them to spend more time on skills practice. Here's an example of the pre-course work for ACLS. You can see that there are a number of lessons that the students will progress through before they get to the end. And there'll be some knowledge checks along the way to make sure that they are paying attention and learning. At the end, they will receive a certificate that shows that they completed the pre-course work, and they'll be able to bring that to class to you. That one certificate that shows that they've completed pre-course work includes both the pre-course work and the pre-course self-assessment. So the two certificates will look very similar. So make sure you pay attention to which one is which. But if the student is doing the entire package, the pre-course work and the self-assessment, the certificate will say pre-course work. Second is pre-course self-assessment. This is what you're familiar with. The students just go on, they take a test, it identifies which areas they need to study more on and which areas they're more strong in. And then they're able to bring that certificate to you if they pass with at least a 70% or higher. Students can access the pre-course self-assessment and pre-course work on elearning.heart.org. This is all free, and this makes it so that training centers can advise every student to look at these, to go through these educational items, get as much information from it as they can, and then come to class well prepared. Right now, these have been translated into English, but as we roll out translated products, you'll see translated versions of the pre-course self-assessment and pre-course work online as well. So look out for more communication from us over the coming months. Let's move on now to some educational concepts. So one of the things that you'll notice is that many of the scenarios in our videos are tailored to different audiences now, so that we can focus on contextualizing the message as much as possible for each student. So if you have students that are primarily from the pre-hospital setting, you can focus on them with specific videos and specific discussions. And also if they're in facility, emergency department or ICU or other clinical staff, you can focus more on them using specific in-facility cases, videos, and testing components. Another new component is the online exams. This is for BLS, ACLS, and PALS for instructor-led training courses. Online exams improve exam security, and they're another way that the AHA is trying to ensure that cardholders around the world have met the same course completion requirements for classroom training. For the training center to acquire these, they are free. They can order them from a distributor or from Shop CPR. These will come in the form of keys that they can then distribute either via Training Central or via email to students' accounts on the day of the class. The instructor or the training center can distribute these to the student. Student can complete them either on a device that is provided for them by the training center or their employer, or their own personal device. The exams will appear one at a time on the screen as the students go through, and the exam will be graded automatically. The one challenge that I will note is that right now, remediation is not supported by online exams. So when the student completes the exam, it will generate a certificate that shows you the student's name and the score that they were able to achieve by taking the exam. But it doesn't isolate the specific questions that were correct or incorrect. So any students that need remediation will have to follow this up with a paper exam for now. Although I will say in the coming months, we are hoping to add that functionality to this, where a student who needs remediation will get a more detailed analysis of their questions. So keep that in mind as you're looking to integrate this into your training programs. This is not really new. We've had this for a few years now, but I wanted to re-highlight this. Open resource exams, this is our policy for exam taking, that students are allowed to take exams and use these resources around them. So they can use their provider manual, whether print or ebook, notes that they took during the course, any posters, the AHA handbook of ECC for healthcare providers, or the guidelines. Any of those resources are acceptable for students to use. However, we don't want students to be collaborating with each other on the exams. We do want each exam to be an individual effort so that the instructor can evaluate the knowledge that each individual student has and provide them customized feedback and remediation if necessary. It's important to know when and how to provide remediation for students. This helps instructors guide students to successfully complete the course. So for students who do not perform well on the written exam, they get less than an 84%, instructors can sit down with them and review the questions that they missed, and then allow them to retest and hopefully get a better score on the other version of the exam. This will help as you can identify specific areas that students have as weaknesses, talk through those with the student, and allow them to retest. This doesn't have to happen on the same day. In fact, many times if you have a class that goes very long, you can review the test with the student, give them some topics to study, and they can come back to the training center on a different day just for the test. With skills, you would approach it in a very similar manner. If a student is not able to pass a skills test, you would review the skills test with them, give them a chance to practice, and then give them a very similar or the same scenario again to practice through and demonstrate those skills. While the student is remediating, you can give them some time to review on their own. They can use a blank skills testing checklist, descriptors of the critical skills, and their provider manual to refresh their knowledge a little bit more as they prepare to retake the test. Megacode testing is now focusing more on testing as a team as opposed to testing only a team leader. So the team needs to work together to achieve a new objective goal of chest compression fraction greater than 80% and meet all of the requirements for critical skills to pass the Megacode test. So there's a lot more focus on the skills testing checklist this time on objective testing as opposed to subjective testing. As usual, all of those skills tests documents will be in your instructor manual and posted on CPR Verify. The English translations of many of those things are already posted and available, and translated versions will roll out as they are completed. So what are the objectives of the Megacode testing station? So obviously CPR quality and timing is the primary goal. We want to make sure that we have a chest compression fraction of greater than 80%. This is a very objective measure. Instructors have clear guidance in the instructor manual how to measure chest compression fraction. Also, we should be using feedback device during compression so that we're measuring depth and rate appropriately and making sure to watch that the compressor always allows full recoil. We want to look at team communication. What is the knowledge that these participants have of the case material and the skills? Do they have a knowledge of the algorithms? Are they able to interpret the arrhythmias? Do they use appropriate basic ACLS drug therapies? And do they perform as an effective member of the team within their scope of practice? Also, when we go back to the pre-briefing idea that Dr. Mancini discussed, did they work together to achieve those goals that they had established for that case in their actual performance of the resuscitation? Another key concept that's been introduced is that of the CPR coach. The CPR coach is a new role within the resuscitation team. It's designed to promote the delivery of high quality CPR and allow the team leader to focus on other elements of cardiac arrest care, coordinate the team members' efforts, and ensure that clinical care is delivered according to AHA guidelines. This role takes some of the burden off of the team leader with a focus on timing and quality based on the audiovisual feedback device. The CPR coach is built into the high quality BLS learning and testing station, the airway management learning and testing station, and the high performance team's cardiac arrest learning station, as well as the Megacode practice and the Megacode testing station. We've all seen situations in which the team leader got overwhelmed with duties, was working very diligently to effectively communicate and also monitor the quality of CPR. In a real case, in the clinical setting, often something slips. Many times, unfortunately, that's the quality of CPR that gets left behind as team members and team leaders get focused on other topics, distracted by other needs and demands. The addition of the CPR coach to the classroom setting will hopefully be mirrored in the clinical setting as people look to dedicate someone solely focused on the quality of CPR being delivered. You'll see this modeled in the videos, and you'll see this in many of these different testing stations as well. So the role of the CPR coach, we're watching the compressions, we're making sure that they are the adequate depth, adequate rate, allowing for full chest recoil, but also coordinating efforts between the compressor who's rotating off, the new compressor who's going to start, coordinating stops and starts and compressions to match with intubation or delivery of shocks to make sure that we have the highest possible chest compression fraction. And again, in the testing scenario, the team is going to be tested to make sure that they maintain a chest compression fraction of over 80%. So this new role of a CPR coach is going to be very critical. We mentioned pre-briefing, so let's just cover that again. Pre-briefing is a discussion we're going to have before a case scenario where we'll set the stage for the case. What are our goals? We want to ensure that there's a safe learning environment with mutual respect, set expectations for the case, explain any rules for the simulation. Are there any peculiar aspects of the equipment that we're using, anything that we need to simulate versus things that we can actually do to this mannequin? And what are the goals for each case? So that as students are starting their case scenario, they have an idea of what they want to do, what their role is, what they really need to focus on this time. Coming from the last case is debriefing. We'll go into the case, then after the case is over, we'll perform a structured debriefing, which you're very used to. Structured debriefing still, we recommend following the GAS method, gather, analyze, and summarize, where we'll go through this very structured process for gathering information from the team members, reviewing the facts of the case, analyzing what happened, analyzing why it happened, and comparing that to the goals that we had in the pre-briefing section. Did we meet our goals? We wanted to improve our chest compression fraction during this case. Did we do that? We wanted to make sure that we had smoother transitions between roles during this case. How did we do on that? And then we'll summarize and have key points for the next case that will help us to understand what we need to focus on in our next pre-briefing session. Let's move on to digital training. We're going to talk a little bit about the digital training side of things. We believe very, very strongly that resuscitation quality is going to depend on the quality of resuscitation training. So we are on a journey to high quality. You may have heard of our goal that we want to live in a world where no one dies from cardiac arrest. We're a long way from that, but I think we're moving in the right direction. One of the things I'd like to highlight is how we're getting to that direction. So you see on the bottom, we have instructor-led training, which provides all of the foundational concepts of what we do, teaching students, relaying this, giving them time to practice, and so on. If you move up one level from that, you have our Heart Code program. Heart Code is a blended learning program where the student completes a portion of the course online and then goes to a classroom with an instructor, gets feedback, practices their skills, and then receives an AHA course completion card. The training objectives for both instructor-led and Heart Code are the same, but the students take a different path to get there. One of the benefits of Heart Code is that it provides a more consistent delivery of content. We have amazing instructors at the American Heart Association that focus very much on improving resuscitation care. But there also is some variation from one instructor to another in the way that we teach. Providing students with an adaptive learning program like Heart Code that looks at how is the student performing, what are their strengths and weaknesses, and then gives them a guided journey to the destination of mastery of learning, helps to remove some of that inconsistency and provides a customized experience for each student. At the top, we have our RQI program, which you may be familiar with as it's been released worldwide over the last year. RQI combines the cognitive learning online of Heart Code, as well as frequent skills refreshers in person on a mannequin. It's a complete learning system solution that incorporates mastery learning where students practice until they've mastered those skills. It uses deliberate practice as a methodology so that students are able to optimize their retention and shorten their learning curve. Over the long time, we also see data that says that as students practice on a regular basis using the RQI mannequin, their skills improve each time on the first set of compressions. So you may see students get better as they practice during the day, but then after time goes by, we know that skills degrade. But with regular practice, that return to practicing, that first set of skills that they do when they go back into the classroom is better each time. And that's important because that is the quality of skills that we are going to get when a resuscitation occurs suddenly. When someone goes into cardiac arrest, we don't have time to practice our skills or refresh them. We need to have sharp skills, we need to be well practiced, and we need to be fully capable of providing those skills. So HeartCode blended learning provides a number of different benefits. First, it's provided through a flexible delivery method. Students are able to take this course online. They can do it whenever they want. But most importantly, they have to interact with the program. So they can't just sit in the back of a classroom passively and allow the information to go in one ear and out the other, as they say. They have to interact with the program, watching videos, answering questions. It provides a consistent approach that every student has the same objectives, but it does also have an adaptive component where it adjusts the content for each student. So as the students go through the course, the knowledge checks will identify where they're strong and where they're weak, and automatically adjust the flow of the information that they're getting moving forward, so that all students will eventually get from start to finish, but they may all take a different pathway to get there, depending on the knowledge that they already have. It's very flexible, so students can complete this on their own time. And once organizations account for administrative and labor expenses and eliminating some of the time of being in the classroom, it's also very cost efficient. That said, we do make sure that every student has an opportunity to put hands on a mannequin and practice skills. I don't believe that online only training provides a valid educational experience to learn a psychomotor skill like CPR, and the evidence supports that opinion. So we always require that a student, after they complete the online course, they do a hands-on skills session, either with an instructor or with a specially designed mannequin that can measure the quality of CPR that they're doing, like the RQI program or the HeartCode Complete program. So why blended learning? Well, CPR performance improves. We have customized course experience in HeartCode for each student as they go through. It adapts, it learns their skills and knowledge. It improves staff satisfaction as they have to take less time away from their clinical setting, less time away from their other duties to focus on education and training. Can potentially save costs for the training department, for the healthcare organization. And it is 2020 and social distancing is a very real concern. That's why we're meeting remotely here instead of live and in person. So this gives the opportunity for students to spend less time in the classroom together. All right, our last section is going to be on some more resources that we are providing for the training network. Product and course orientations. So as we release new products, it's important for us to give you some information about each of those products, to tell you what is new about them, what are the features that you can find in them, and what are the things that you should be looking for to help solve your problems in the classroom. So the product and course orientation is developed to do that. First, we developed this as an e-learning course, which is free. You find it on elearning.heart.org. The courses talk about the design and format updates of the courses. It talks about any new components like online exams. It talks about how to use the instructor manuals, and it gives you an overview of the provider manuals. The product and course orientations have been released for BLS, ACLS, and PALS in English. So if you are able to take the course in English, they're available for free on elearning.heart.org. You do not get a certificate for completing the course. It's for your information only and to help you familiarize yourself with these new materials. For translated products, we translate a document that summarizes this information, and we release it on CPR Verify at the same time as the release of the instructor manual. So when the instructor manual comes out in your language, you can look on CPR Verify for a document called Product and Course Orientation, and you'll see a translated document that will give you guidance and knowledge about all of the different components of the BLS product, ACLS, and PALS as those come out. So while we're on the topic of CPR Verify, remember that you can always find resources for training on CPR Verify. When you first log in, you'll have the dashboard in front of you. Always look for notifications that will tell you new and exciting news from the AHA, or maybe something that's really important for you to know. Along the top, you'll see a line of buttons. Under the Information tab, you'll find all the files that you need to teach a course, like skills checklists, rosters, and printable lesson plans. You'll also find things like the product and course orientation document. If you need exams, contact your training center coordinator. They'll have access to the new exams on CPR Verify as well. We're also very excited to announce, for the first time, that we're making a complete overhaul of CPR Verify right now that will be available in 2021. We don't have a name for it yet, where right now it's being referred to as a global learning platform, where we're going to take just an amazing amount of feedback from our training network, from our internal staff, the way that we interact with CPR Verify and the benefits that it gives to the training network. And we're going to improve all of these things and provide a better experience for you as an instructor, as you run your training center, and for your students as well. We want to provide a much more comprehensive program that's more user-friendly and more easily translated as well. So look for a new program with a new name, a new look and feel, and more benefits to you as an instructor coming in 2021. For more information, you can go to our website. You can look on our website, international.heart.org. That will give you information on where to buy the new materials. You can find information on when the new materials will come out. You can also find links to our ebooks there. So if you want to start ordering some of the ebooks, particularly those that are already translated or those that are available in English, you can acquire those now and start to review them. And then finally, most importantly, eccguidelines.heart.org. If you have any more questions about the guidelines, you want to review the full guidelines document in English or the guidelines highlights translated into your language, you can do that there at eccguidelines.heart.org. We're going to move on to some questions now. So, what about skills testing with digital learning? So skills testing and remediation of skills is done just like in an instructor-led course. We use the same skills checklist. We have the students demonstrate the same exact skills. And if they're unsuccessful, we remediate them in the same way. With digital learning, the students don't have to take an exam, a written exam in the class. For example, if a student has completed a BLS Heartcode course, they will not have to take the written exam when they come to do their skills session. When an instructor card is issued, is it valid for 2 years from the date of the course or the monitoring? That's a great question and one that we get a lot. The instructor card is valid for a period of 2 years from the date of successful monitoring. Most instructor candidates only need to be monitored one time to be successful. That doesn't mean that they're a perfect instructor or that they're a veteran instructor. It just means that they've met the requirements to be an instructor. Improving as an instructor is a lifelong pursuit, and we can all find ways to improve. This is one of the reasons why instructor cards expire, and we want every instructor to be monitored every year so that they can be given feedback on their instructional technique and how effectively they deliver the educational content. So that said, when an instructor does complete their first monitoring, they should be issued an instructor card that is good for 2 years from that monitoring date, although at the end of the month. So 2 years to the end of the month. Due to COVID-19 restrictions, very few courses are being held. Will there be a provision for the 4 courses requirement? Yes, so if you're familiar with the requirements for renewing instructor status, every 2 years, instructors have to teach 4 courses in each discipline and be monitored and attend any updates in order to renew their instructor status. Well, if you're here today and you take the quiz at the end and get your certificate, you've completed your update. You also do need to be monitored, but we are working on a new policy for renewing instructor status in light of the COVID-19 training restrictions. So look for communication from us in January, probably, where we'll give you some better information on how you can renew your instructor status in light of all of the challenges that we've had this year. Okay, so can we space an ACLS course over 3 days? Yes, or more. We've had a number of training centers that have done that, like we mentioned before. And sometimes they'll break apart individual modules and deliver one module of the ACLS course each day, or one module of the PALS course each day. It's a little more difficult to break apart a BLS course like that, which is why a lot of training centers end up with the solution of using HeartCode, because it removes a lot of that educational delivery from the content, from the classroom, and students can do it in their home or office and then come to the classroom just for the skills session, which is much more flexible. We want to thank you for being here. We want to thank you for all of the work that you do to improve resuscitation training and resuscitation care. At the American Heart Association, our mission is to help people live longer lives, to be a relentless force in the pursuit of longer, healthier lives. And we couldn't do that without our instructors, you. So thank you very much for all that you've done and for all that you continue to do. I hope you found today's session very helpful and the information useful. Please feel free to send feedback to us and share with us your thoughts about the session and how we can improve in the delivery of future webinars. Now, you want to get a certificate from this program to give to your training center to show that you've completed this. So we're going to drop the link in the chat box, and you can take that link and follow that link to a quiz, which will be delivered in your language. At the end of the quiz, if you successfully complete it, you will get a certificate showing that you've completed your instructor update. Thank you again for coming, and thank you for your time.